This project is by Jaslyn, Jennifer, and Severo. We will be your expert speakers on diabetic ketoacidosis, also known as DKA. Here are our objectives. We will be going over diabetes and DKA, signs and symptoms, how the body is affected, prevention, and treatment. Diabetes is a chronic condition that affects more than 30 million people in the United States. It affects 1 in 4 people over the age of 65. The CDC states that DKA is a life-threatening but avoidable complication of diabetes that has increased in hospitalization rates by over 6% annually. When treatment is not delayed, there is only a 1% fatality rate. DKA is considered a metabolic derangement that is characterized by 3 things: hyperglycemia, levels that are above 250 milligrams per deciliter, metabolic acidosis, levels usually less than 7.3, and ketosis, which is elevated ketones. In a healthy body, cells use glucose for energy. Glucose is the main source of fuel for the brain, which cannot produce or store copious amounts. As such, the brain is in need of a continuous supply of glucose in order to prevent cell death. So imagine you have a bunch of dairy cows roaming about, but no one is ever there to milk them. They have the milk available, but no way of getting the milk out of them without a dairy farmer. That's essentially what it is like for diabetics who do not have insulin. They have glucose available, but have no way of getting the glucose inside the cells without insulin. That is why type 1 diabetics and often type 2 diabetics must inject themselves with insulin in order to get the glucose inside of the cells. If the body does not have any insulin, the glucose remains in the blood, causing hyperglycemia. The body is unable to detect the glucose since it remains outside of the cells and is then tricked into thinking there is no glucose in the body, and then it continues to release more, causing even more hyperglycemia. Since the body thinks there is no glucose, it enters into backup mode. That is why insulin is so important. It transports the glucose into the cells and energy is restored. Now, in diabetic ketoacidosis, the body has gone past having little insulin to having no insulin whatsoever. In an attempt to preserve life, the body begins to look elsewhere for an energy source. Eventually, the body starts breaking down fat to use as fuel. The problem with this is the body then begins to have a buildup of acids in the bloodstream called ketones, which is the keto in ketoacidosis. The ketones act like a backup generator. The problem now being backup generators are only supposed to be temporary until the main power source is restored. So unless the body gets back to having insulin to utilize glucose, the ketones continue to build up, causing the body to become acidic. The blood pH drops below 7.35 and the body enters into metabolic acidosis.
So how does someone get DKA? DKA mainly affects type 1 diabetics, but can also affect type 2 diabetics, all of which may experience extreme illness or unusual psychological stress. Examples of psychological stresses that can cause DKA include acute infection, pneumonia and urinary tract infections, myocardial infarction, stroke, pancreatitis, pregnancy, and trauma. Medications and drugs such as thiazide diuretics, sympathomimetics, or norepinephrine, epinephrine, dopamine, and cocaine, and sodium glucose co-transporter 2 inhibitors can also be a causative factor. Other causes of DKA may include noncompliance with insulin regimen, including being unable to afford medications or improper education regarding insulin administration, alcohol abuse, trauma, surgery, pulmonary embolism, and new onset of diabetes. These conditions cause the body to require increased insulin as blood glucose rises during these times of stress. Without having enough insulin to meet the metabolic needs, DKA is then triggered. So how do we diagnose DKA? Laboratory findings with the serum glucose levels above 250 milligrams per deciliter, Serum ketones positive in the blood. Your serum pH is less than 7.3, which would mean you're acidic. Serum bicarb, which is less than 15 milliequivalents per liter, which would bring you in the acidic range. Serum sodium is low, normal, or high, so it can vary or fluctuate. Your BUN is above 30 milligrams per deciliter. This is usually caused by dehydration. Your creatinine levels are above 1.5 milligrams per deciliter. Again, this could be from dehydration, or it could also be from impaired kidney functions, which is common with diabetics. Urine ketones are positive. If there's too much ketones in the blood, your body tries urinating them out, so you'll see them in the urine, which they're not supposed to be there. And serum anion gap is greater than 10 milliequivalents per liter. This could indicate metabolic acidosis. Other imaging and other diagnostics. There are no specific imaging tests needed to diagnose DKA. However, they may be needed for the causative agent. Since DKA is usually brought on by cases of extreme illness, MI, or even pregnancy, it is necessary to run other tests such as an electrocardiogram. An ECG is useful to monitor for any potential life-threatening rhythms related to hypokalemia or hyperkalemia. Blood cultures should also be obtained in the case of presenting illness, as a pregnancy test for females or childbearing age should also be performed. A chest x-ray may be needed in cases of pneumonia. Pneumonia and urinary tract infections are the two most common infections that precipitate DKA. Signs and symptoms of DKA. Surprisingly, DKA primarily occurs in younger people aged 11 to 15 years, followed by adults younger than 30, and those between 30 to 50 years. Females and immigrants are more at risk of developing DKA. DKA initially presents with signs and symptoms similar to hyperglycemia, such as increased thirst, increased urination, and increased hunger. Increased urination, or polyuria, causes many complications such as electrolytes, especially potassium, are depleted. Serum potassium must be monitored and replaced, or life-threatening hypokalemia may result. The increase in volume depletion eventually leads to other complications that can include dehydration, nausea, vomiting, abdominal pain, lethargy, tachypnea, facial flushing, dry mouth, fruity smelling breath, headache, muscle stiffness, or aches. A physical assessment might reveal tachycardia, hypotension, small respirations, or a change in mental status. A delay in treatment could lead to a coma or even death.
So for treatment of DKA, so for the nurse's role, we would be managing their blood glucose and monitoring. We would do monitoring for signs and symptoms of DKA, looking at their vital signs every 4 hours. And I feel like the most important would obviously be the fluid electrolyte management and drug therapy. So for fluid and electrolyte management, we would do IV hydration therapy, which is really important because patients can lose up to 15% of their body weight because of dehydration. So it is important that we do an immediate fluid replacement. This will help correct the hypovolemia, raise some blood pressure, restore perfusion, and get rid of the ketones in the body. For DKA, usually we would use normal saline. This is important to lower the blood glucose levels. For the electrolyte management though, we would try to prevent the drop in potassium. So you would probably get started on some potassium IV, because it also, with insulin therapy, you can get hypokalemia. And also we should monitor sodium levels and magnesium. And hypokalemia is often the number one cause of death when treating patients with DKA, so we'd really have to monitor that. potassium and make sure that they're getting that IV therapy, and like always looking at the lab levels. And then next is drug therapy. So with drug therapy, it's really important to look at their blood glucose level and see how much insulin they will be needing, and usually it's done through the IV bolus. It's regular insulin. We do 0.1 units per kilogram per hour, so this is really important. And then last but not least, the precipitating events. So we would just have to prevent another, obviously, DKA and look for what preceded this DKA. So sometimes it can be non-compliance to medication, trauma, a pregnancy, heart attack, pancreatitis, alcohol abuse, an accident, or new onset of diabetes, which wasn't controlled. And then what can be delegated to an LVN or UAP. So for LVNs, they can monitor vital signs once they are already stable. Do AccuChecks, so look at their blood glucose and report to the nurse. Monitor INOs and sub-Q insulin therapy. For UAP or CNA, ADL assistance, just the little things that they need help with. Vital signs as well, bathing and turning, and going to the bathroom and toileting needs. So for prevention of DKA, it is very important to educate the patient on managing their insulin, any other diabetic medications, and the disease process, and what can occur if they do not manage their diabetes. It's also important to let them know about food and their meals, and how they're skipping meals or having too much food can affect their diabetes. And also we can help them, refer them to a dietitian for meal planning. Also, they should know how physiological stress can affect their body and increase the body's need for extra insulin. Referring them to a social worker, mental health worker, dietitians, or home health agencies to help monitor their diabetes or be compliant, and help them with their ADLs to make sure that they're being compliant. Also, of course, adherence to medication regimen. They should take them as prescribed. Monitor the glucose and monitor for signs and symptoms of DKA or hyperglycemia, which will be really effective in preventing DKA, and helping them too with maybe organizing medications and stuff. Like home health can help them with that. And also knowing risk factors for DKA, like females, being an immigrant, infections, alcohol consumption, and medical compliance can all lead to DKA. So if we can prevent this and educate them and help them know what can cause it, then we can prevent this. So question number 1, which of the following are signs or symptoms of diabetic ketoacidosis? Select all that apply. A, positive ketones in the urine. B, oliguria. C, polydipsia. And D, abdominal pain. You can pause the video and think about your answer. But the answer would be A, positive ketones in the urine. C, polydipsia. And D, abdominal pain. So question number 2. A nurse is caring for a patient who was admitted for uncontrolled diabetes mellitus type 1. In the event that DKA does occur, the nurse should anticipate to administer which of the type of medication? A, regular insulin. B, glucagon. C, glyburide. And D, NPH. So the answer would be regular insulin, because this is the preferred treatment, because regular insulin is the only one that you can give by IV. Question number 3. Which patient is most likely to develop diabetic ketoacidosis? A, 45-year-old who is compliant and takes insulin as needed. B, patient with diabetes mellitus and has not had a meal in 2 days due to bowel obstruction and has not had insulin. C, 28-year-old who was recently diagnosed with type 2 diabetes. D, none of the above. The answer would be B, a patient with diabetes mellitus and has not had a meal in 2 days due to bowel obstruction and has not had insulin. So they are at risk for hyperglycemia, which can then lead to diabetic ketoacidosis.
Here are our references, and the layout was also designed by SlidesGo and FreePay.